This is the first in a series of respiratory lectures, and this one we're going to cover asthma, a very common complaint of people, and we'd like you to understand that more. This is Dan Limmer, here with my friend Dan Batsie, who's going to start with our scenario this time.
All right, so you're called for a 14-year-old female patient. Her mom says she's been struggling with an asthma attack for the last 2 hours. She's tried multiple different rescue inhalers that are prescribed by a physician, but mom called EMS today because she's just not getting any better. You arrived to find her in severe respiratory distress with obvious wheezes coming from her chest, and she's really struggling to breathe upright in a nice tripod position. So you begin the transport immediately. You begin some of the interventions. About halfway through your transport, though, while your back is turned, you turn around and she's not breathing anymore.
Wow. It's a 14-year-old makes it very scary, and it's not the most common thing in asthma, but boy, it certainly can happen. I mean, that is the end result if it's not fixed.
Yeah, there are 3,000 asthma deaths every year outside the hospital. So although it's not a super common thing like cardiac arrest, this is something that we see. This is something that we're on the tip of the spear taken care of.
Yeah, and we have the ability to provide some significant help in this. We'll talk about that, but I think that the pathophysiology comes first, because there certainly are some things that if we understand what goes on in the lungs and even some of the triggers perhaps, we would be able to kind of put together this asthma thing more. You know, you get to that 14-year-old patient and you're probably not thinking COPD or something. I mean, the mother says she has asthma. You know, we talked about the things sometimes that are obvious, and that may be the case. But we have some triggers we want to think about, and then also what happens in the airways themselves.
Yeah, we talk about the idea that asthma is a chronic disease that's episodic in nature. And that is, this person has this disease now, they've had it for years in many cases, and that's not the underlying problem. The problem is a flare-up of the disease, particularly in bronchoconstriction. There's really three problems that an asthma patient has. The first is they have a little bit of swelling in their airways all the time. The tubes are just a little bit inflamed all the time. The second thing is they produce a little bit more mucus than you and I, and that mucus can obstruct flow in the airways. Now, those two things in and of themselves are very manageable, and in fact, there's professional athletes that have asthma that manage it quite well. It's not until they get to the third phase that generally we see them, and that third phase is bronchoconstriction, bronchospasm. And in response to a trigger, and triggers vary really from anything from dust and pollen, mildew, humidity, stress, cigarette smoke, literally dozens of other possibilities.
Some respiratory infections can do it, right. Exercise occasionally.
But for whatever reason, for whatever trigger it is, the bronchial tubes in a very acute fashion constrict. And that bronchospasm significantly limits the amount of air that can come in and get out of that person's lungs. And that leads to hypoxia. It leads to an increase in carbon dioxide retention and, in many cases, death.
Yeah, it becomes so much harder to move that air in and out, sometimes especially out, to be able to move that. I have sometimes heard people talk about the blowing up the balloon analogy. You blow up the balloon, the air goes in, but then you pull the neck, it's constricted, and it makes that noise coming out. Yeah. And you get that wheezing many times on exhalation, but in some cases all the time.
Yeah, certainly the hallmark of this condition is the wheeze, right? And a lot of times it's audible right from across the room. In some other cases, we can hear it with a stethoscope. I think it's kind of interesting to know that usually the louder and more pronounced it is, generally speaking, the more air they're moving. And as they get sicker and sicker, that is, they move less and less air, that wheeze becomes harder to hear and more fine as they refer to it.
Yeah, well, the silent chest is not a good thing in any condition, but really a loud wheeze is good, and becoming softer to non-existent often indicates, especially if it's not being treated, that respiratory failure is ensuing.
Yeah, I want to go back, Dan, and we talked in a previous podcast about alveolar ventilation, and that is the key to the respiratory system is getting air down to those alveoli. And in this particular case, because of that bronchoconstriction and the inflammation, what we're seeing is a person who can't get air down there, and in some cases, although they can get air down there, they can't get air out. So that lack of transfer from air in and air out of the chest leads to very deadly conditions, hypoxia, hypercapnia, that is, high levels of carbon dioxide. And the body is going to then respond to that, not just with we talked about the wheezing that we hear, but also with respiratory distress. These people have a difficult time breathing. They increase their respiratory rate. They move to what we call the tripod position, in a bolt upright position where they tend to lean upon their arms, and that allows gravity to help move air in and out of their chest. They use accessory muscles, particularly in their neck and their shoulders, to help try to pull air in. And these things become apparent when you look at them and when you examine them.
So you really have given a great list of the signs and symptoms, ultimately, of asthma, as we went from pathophysiology and describing what happens from the normal little bit of swelling and mucus production to becoming more critical and either spasms or very constricted, that we've gotten the signs and symptoms of wheezing, the perception of difficulty breathing. They may get in the tripod position, accessory muscle use, and with that sometimes comes significant anxiety with hypoxia that develops, and people, I've seen them get really bad that way.
Yeah, and let's not forget about history as well. There are very few new onset asthma patients. Almost everybody that you're going to encounter with this problem has a history. So taking a few seconds to ask about medical history and talking about their history of this disease is really relevant. The other thing that's relevant is how bad they've been in the past. And we can show you that there's a correlation between death from an asthma attack and things like, have they been hospitalized in a previous year? Have they had to be intubated in the previous year? Have they used more than one canister of rescue inhaler in a month? Now, none of those things are going to definitively tell us whether the person's in critical condition now or not, but I think it's important that they help us establish a threshold of just where they've been in the past, and that's sometimes a really helpful thing.
No, those things are, if you get someone, I had a patient we were transporting to the hospital, and his caregiver was there, and we went through, and I thought I did a really great history, and someone just casually mentioned, oh yeah, last time he had an asthma attack, he almost died. And that is significant only because it will help you prepare for the worst. There's certain things you should not be surprised by. And by finding out, there's questions. I go through and do a history on every patient. You ask, do you have, tell me about your condition. You go through the whole thing. I like to ask people, have you ever been admitted to the hospital? Have you ever been admitted? And they may say, well, I had gallstones, might be totally unrelated. But you get these respiratory patients, say, have you ever been admitted before? And they say yes. It's a question. Every resident admitting someone to the hospital asks that question. Yet we don't think to ask questions like that, and they tell us a lot. So then we get to say why. And again, it's that path we take in getting a history.
Yeah, very relevant, particularly in this kind of patient here as well. I think when we talk about what we're going to do for these patients, I don't want us to forget about primary assessment, because so much of what we're going to do depends upon what we find in that initial assessment of both their airway and the adequacy of their breathing. Many of these asthma patients, particularly as the asthma attack goes on and on and on, will begin to fatigue, and although they may still be breathing, may not be breathing adequately. So we really want to take time in our primary assessment to make sure that the breathing they're doing is actually meeting their metabolic demands.
And follow that throughout the call.
Yes.
Because we'll see them in the beginning, and if they seem to go downhill, either in their respiratory effort or even their mental status, those are all clues that are going to tell us that they're sick.
I love mental status when looking at breathing adequacy. I think so much of what our respiratory system does is supply our brain with oxygenated blood, and when that respiratory system fails, we tend to see the altered mental status that you talked about, even things like anxiety, but then as the condition gets worse and worse and worse, increasing altered mental status as well.
Between us, we've probably been to thousands of respiratory patients, many of which have been asthma patients. And the respiratory patients in general, and the asthma patients, either the patient themselves or maybe a parent or somebody else is going to hand you inhalers.
Right.
They're going to say, this is the that they use. Now, they may have a small volume nebulizer at home if it's a really bad thing. There's really two big schools of inhalers with two main purposes, because ongoing care, we can take the medication, the beta-2 agonist medications, the albuterol medications, and we can reduce that spasm and constriction. But unless we deal with the swelling and mucus, they're never really going to get better. So there's two different medications.
Right, yeah. And I think it's really important to understand that this is an EMT intervention, that EMTs make these people better. And the care, even though you may not cure the immediate situation, the care you deliver on scene right away impacts the outcome of this patient. When you deliver beta agonist inhalers, for example, the sooner you get those on board, we know it tends to delay the worsening components of the asthma attack, the increase in inflammation, the increase in mucus plugging, if we can just get those airways opened up. And that is absolutely something that happens before the paramedics get there, before the patient's delivered to the hospital. That's within the grasp and the scope of practice of an EMT.
And I think that's really important, is that we're more and more seeing EMTs with small volume nebulizers. Now, you mentioned inhaler. We have small volume nebulizers. Both are very valuable. Sometimes people say the nebulizers, but an inhaler, especially when it's used properly, gets that medication down there and can be very profoundly effective.
Yeah, absolutely. Absolutely. I mean, any of the methods of getting the beta agonists and the bronchodilators, if you will, into this patient are really vitally important, especially in the early phases of the attack.
Yeah. Really putting this all together, getting a good history, and then you're assuring that they have a history of asthma, really appears to be asthma, and then being able to go in the medication. Well, you want to obviously be sure. You don't want to delay, as you say, that is just so really important to get in there. And again, I think that this is very, very much in the scope of an EMT to do. I think that's really important. Too many systems, either wait for paramedics or are somewhat paramedic driven. But everything from coaching a patient and assisting them with their own inhaler to do it right, to using a medication that you carry and have in your protocols, very, very much in the wheelhouse of the EMT. Yeah,
and let's not forget about another medication that we oftentimes do forget about, especially these days, is oxygen. The reason these people die is hypoxia in many cases. So we definitely want to be using the tools to measure that, like pulse oximeters, but also to deliver the oxygen that these people need. Now, that's not a license to deliver unfettered oxygen without thinking about it at all. And certainly we want to, like in many other cases, titrate that oxygen to a normal oxygen saturation. But these patients, particularly in the end stages or the latter stages of these attacks, will get hypoxic and need in many cases, high concentration oxygen.
Let's talk about the inhaler that's not the rescue inhaler, the steroid inhalers. And there's a lot of different brands, and there's a lot of different types out there as well. But the patient with an asthma condition generally has two inhalers: the rescue inhaler, the beta agonist medication. Then they have some type of steroid medication, an inhaled steroid. And there's lots of different kinds of inhalers. There's that purple Advair inhaler. There's a lot of different kinds out there now. But I say this for a couple of reasons. One, to reemphasize what Dan said about that ongoing care requires the use of something to reduce the inflammation and the mucus production, because that is a chronic disease. That doesn't totally go away. And many people that don't address that, their asthma is dramatically worse.
Yeah.
So, but I also want you to make sure is that when you assist someone with their inhaler that's having an acute attack, you also have to make sure you're using the one that's designed to bronchodilate and not the steroid inhaler.
Yeah, and I certainly don't want to I don't want to minimize the value of the steroid inhalers for daily maintenance or weekly maintenance. Those are really important. And if you actually look at the people who die from asthma, the majority of them are not controlling their asthma well. So I think that's really important. But as Dan said, it is really important to differentiate those inhalers in the sense of a rescue inhaler is the one that we want to be giving right away. And that's usually the beta agonist.
I think that obviously with the treatment that we have with our beta agonists and giving some oxygen, that we have the potential to make these patients well, to really turn it around. We're still going to transport them, and they're going to have to get some ongoing care. But there are times when we get there and they are too far along to really get the medications in, or maybe it progresses very rapidly, and they can get into respiratory failure. Let's just, we always wrap these up with a little bit of an insight or different things. let's just talk about what a patient in decline would look like once more and figure out when we're looking to use an inhaler and when we're looking to ventilate and the importance of that.
Yeah, one of the challenges that these patients have is the muscles they use to compensate, all the additional accessory muscles they use, and all the efforts they do to keep themselves alive require more oxygenated blood. And unfortunately, in this condition, they're not getting the oxygen into their system. And that leads to this sort of deadly spiral where eventually these muscles are going to fatigue and they're not going to be able to compensate anymore. And that's the classic presentation of an asthma patient, is that compensate, 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 fatigue, 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 die. And it's really important for us to recognize that spiral, to recognize and intervene before they get to that place. I think some of the things that we're looking for right off the bat, Dan, is they'll simply say, I'm tired. I can't keep doing this. And difficulty speaking is another big one as well. We know that the number of words they can speak in a sentence consecutively without taking a breath really does correlate to the level of their severity, those things like that. More importantly, though, and we mentioned it before, mental status. As they begin to fail, we'll see decreasing mental status, and that's a very important finding to recognize. We also talk about silent chest, putting a scope up against their chest and actually hearing how much air they're moving or lack thereof is really important as well. Other things that we think about, slowing or irregular breathing is an important hallmark to that respiratory failure and one that we need to recognize right off the bat. And then finally, continued hypoxia, especially despite supplemental oxygen. These are all very ominous signs as well.
And it's okay to ventilate an asthma patient. When it gets to failure, we're going to ventilate, but that's not without risk, I guess.
Yeah, the challenge of this is, so one of the big issues that an asthma patient will have, and in many cases one of the large elements of their ultimate demise, is the fact that they're trapping air. Those little mucus plugs are blocking the flow of air out of their lungs. So in many cases, it's not getting air in that's the problem, it's getting air out that's the problem. And when you come along with your positive pressure bag mask device, you're actually increasing the amount of air that's in there. So that means we really want to avoid that until it's absolutely necessary to do it. The problem is sometimes it is necessary to do it. And usually what we think about, and when I teach my students, I think about this, the goal of ventilation in an asthma patient is to relieve fatigue. When they can't do it on their own, that's our sign, that's our marker to say, do this now, to ventilate now. So when you're seeing the signs of fatigue that we talked about, when they're slowing down or becoming irregular, or they're unable to breathe on their own, especially if they become apneic, that's the time that we need to get in there. But we do want to avoid that until that moment because we don't want to make the condition worse.
I think it's very difficult, to find those times, understanding the pathophysiology and why we do it. And quite frankly, across a wide span of emergencies, we've learned that voluminous, forceful ventilations are bad for everyone. And I think in this case, we've established why it's very bad for a patient that might be in the critical stages of an asthma attack.
Yeah, for sure. And then also to remember that at that point, advanced life support becomes incredibly important because the medications that we're delivering by the inhaled route may not be effective anymore, and they may need to find a different route for medications to reverse this condition.
It is a team thing, and that hopefully that this information we've learned about asthma in our lecture series will be beneficial to you and your patients. This audio lecture is presented by Limmer Creative, experts in the science of pathology. For more audios as well as other educational resources, visit www.emtreview.com.